So I'm probably going to get started. I can see sort of people still coming on. But again, I just wanted to, I guess, start in the interest of time. I'm delighted to welcome everyone to the SHN Medicine Division Grand Rounds. I want to extend my appreciation to Dr. Tsien for her willingness to present to our group. And we really are truly fortunate to have her share her expertise with us today. I'd also like to thank Janet Armstrong and her company Lupin for their generous support and assistance in coordinating this event. Now, let me introduce our distinguished guest, Dr. Cynthia Tsien. Jokingly, again, me and her differ just by one letter in the alphabet, but again, her knowledge base is way more than that. She currently serves as an assistant professor of medicine and transplant hepatologist at Toronto General Hospital. She holds multiple leadership positions, which include the Fellowship Director for Transplant Hepatology, Program Director for Solid Organ Transplant, and Education Director at the Edgemere Transplant Center. She completed her training in medicine and GI at McGill, and then pursued further subspecialty training in hepatology and transplant at U of T and the Cleveland Clinic. Her research interests encompass cirrhosis, portal hypertension, and sarcopenia. Once again, I thank Dr. Tsien for joining us today, and I look forward to our enlightening presentation.
Thank you so much. I just wanted to say that this is going to be very informal. There's some opportunities for reflection, and I might ask you guys some questions. So really feel free to interrupt at any time to ask questions. It's very informal. So this talk is sponsored by Lupin. I received some honorariums and educational grants from various companies. And the objective of the talk is to kind of give you an overview of the UHN liver transplant program and the program outcomes, and then really focus a lot of the talk on the role that community gastroenterologists and internists play in the pre and post-transplant care of patients, and really using an ALD case study to talk about, indications for transplant, changes in the transplant assessment. So there's no longer a 6-month rule for patients with alcohol-related liver disease. And just finish up very quickly by saying, is there an opportunity to share in the post-transplant care? So these slides are courtesy of Dr. Lilly, one of my colleagues who's been at the liver transplant program in Toronto much longer than I have. And as you can see, the transplant program started in 1985, and we currently follow, we've done over 4,000 liver transplants, and we follow over 3,000 patients currently. You can see there that we do approximately 200 liver transplants a year, and about 60 to 65 live donor liver transplants. So for adult liver transplants in North American centers, we usually are in about the top 5 of transplant centers in North America. And the live donor liver transplants has been steadily increasing since 2016. We've actually done the 1,000th live donor liver transplant in 2022, and have done over 1,100 live donor liver transplants at this point. And I think we're the largest program in 2021, and then dropped to second in 2022, but also usually in the top 3 for live donor liver transplants in North American centers. Usually we have approximately 30 to 35% of all of our transplants are from live donors. And if you look at the average sodium MELD score of deceased donor versus live donor patients, you can see that live donors generally have a lower sodium MELD score, which makes sense as we're able to do these transplants earlier, which is significantly lower than the deceased donor recipients who have MELDs in the 28 to 30 range. And there have been significant changes in the indications for liver transplant over the years. So from 2017 to 2021, the number one reason for liver transplants was for alcohol-related liver disease, followed by NASH and viral hepatitis. So hepatitis C, hepatitis B, and then we had smaller numbers of PSC and PBC. HCC is not listed here because it's listed according to the underlying liver diagnosis. But in general, as I'll show you later, usually it comprises 30 to 40% of all liver transplants. And you can see that you guys have been doing an amazing job treating hepatitis C. We no longer have hepatitis C anywhere, or at least our liver transplant program doesn't see any more hepatitis C. So whereas in 2008, 41% of transplants were done for hepatitis C, in 2022, it's dropped to less than 10%. And the majority of transplants for hepatitis C now are being done for concomitant hepatocellular carcinoma, whereas before it was for decompensated hep C as well. So with less hepatitis C, we are seeing much more alcohol and NASH cirrhosis. So you can see here NASH and cryptogenic cirrhosis has been steadily increasing over the decades. And for alcohol-related liver disease, you can see, interestingly, there was a spike in 2018 when the new guidelines for transplantation were instituted. This pilot program was started in 2018 in Ontario, kind of leveled off. And then I think, in 2020 with the pandemic, I think everybody recognized that there was an increase in alcohol consumption, and then our numbers went up for alcohol-related liver disease again. Here it shows the number of transplants for hepatocellular carcinoma at UHN. And as you can see, usually it's anywhere from 30 to 40%, holding pretty steady for the proportion of patients done for hepatomas. Our transplant waiting list is usually around 250 patients at any one time are waiting for a liver transplant. And the mean MELD is 19, and the median MELD is 21 for active patients only. So patients who are not doing their blood work on a regular basis are inactivated. So these are for active patients only. And unfortunately, despite all these transplants that are being done, we still delist approximately 30% of patients every year. So we will transplant 2/3, but 1/3 are delisted. And the majority of the reason is because they've either passed away, are too sick, or their tumor has progressed. So that is the majority of patients that we remove from the wait list. So despite all these transplants, unfortunately, 20 to 30% of people are being listed and then not going to transplant because of death or being too ill or tumor progression. What does survival look like? So we have excellent graft and patient survivals. You can see here that our 1-year graft and patient survival is 90 to 95%. And then the 5-year graft and patient survival is about 80 to 85%. There is improved patient survival with live donor liver transplant. As you can tell, we transplant people with lower MELD scores with live donors. They tend to be less sick at transplant, and they have better survival. So the 1-year survival for live donors is about 95% versus, 90% for deceased donors. So there's no reason not to go with the live donor graft. And in terms of graft survival, the outcomes are very similar to the deceased donors. So I'm just going to pause for a second to see if there's any hands before I go to the meat of my talk. it's hard for me to read the chat, so just raise your hand if you have a question. Um, Hopefully I'll be able to see that. And if not, then I'm going to move on to a case study of a patient with alcohol-related liver disease to really talk about the role of community physicians to care for these patients pre and post-transplant. So the clinical case is a Mrs. J.W. She was a 35-year-old woman transferred from the Humber River Hospital when the program was sort of just instituted in 2019. She was known for anxiety and fatty liver disease since 2015, and 1 week prior to being admitted, she developed jaundice, anorexia, fatigue, and abdominal pain. And when she came in, her blood work was quite concerning. She had a cholestatic hepatitis with a bilirubin of 450. There was a lot of liver dysfunction. Her INR was 2.2. There was concerns for hepatorenal syndrome with a creatinine of 362. Her white count was significantly elevated at 40, and her sodium melt was 40. She had abdominal imaging, which showed hepatomegaly and ascites. And her whole viral, immunologic, and metabolic screening was negative, as well as the infectious screening was negative. And so she told the group that she only consumed 4 to 5 standard drinks per month. And given the concern for alcoholic hepatitis, she underwent a transjugular liver biopsy, as her account of her alcohol consumption didn't really seem to match the clinical picture. And this showed a moderate steatohepatitis with Mallory bodies. So just as a refresher for you, how do we decide whether to proceed with transplant? So, alcoholic hepatitis is a clinical syndrome of jaundice and liver failure that generally occurs after decades of heavy alcohol use and is really a clinical diagnosis with this rapid onset of jaundice. The liver is enlarged and tender. You may see fever, ascites, encephalopathy, and biochemically, there is the AST/ALT elevation that you're all familiar with, and the AST is rarely above 300, and you often see an elevated neutrophil count. And if you do a biopsy, you see these Mallory bodies surrounded by neutrophils and ballooned hepatocytes. And so we really need to be able to prognosticate to determine, which patients will die without liver transplantation. And there's many prognostic scoring systems. I'm just going to focus on a couple that I'm sure you're all familiar with. So we have the Maddrey discriminant function, the MELD score, the Glasgow score, ABIC, and the Lille score. But I'm really going to focus on the Maddrey, MELD, and Lille. So one of the studies that looked at the use of Maddrey score was in this randomized trial of prednisolone in patients with severe alcoholic hepatitis. And they basically took all patients with severe alcoholic hepatitis, so a Maddrey discriminant function greater than 32 or encephalopathy. And I think really what I want to emphasize is if you look at these patients with the severe Maddrey greater than 32, their survival was extremely poor. So if you look at the 30-day survival, it was, just at 50% for patients with encephalopathy. So again, the Maddrey is the DF greater than 32 or encephalopathy because, it does appear that encephalopathy appears to really contribute to the poor outcome. 30-day survival in patients without encephalopathy was just over 50%. With encephalopathy was just at 50%. And if you look at the long-term survival, 90 and 180 days, the survival was below 50% for these patients with severe alcoholic hepatitis. And the other thing you notice is that most of the mortality occurs in the first 30 days. So that is another reason why it's very difficult to, tell people, come back in 6 months and then we'll see if you need a liver transplant or not, because most people will not survive to the 6-month mark. So I think it's also important to recognize encephalopathy because not only does it impact prognosis, but because cognitive damage may not be reversible. In this study that looked at a small number of patients post-transplant, they did a neuropsychological assessment pre and post-transplant, and it showed that 7 patients showed a persistent mild cognitive impairment, which I think we all recognize post-transplant. Some people are not quite the same after transplant. And what they showed was that the more cognitive impairments that you had, so the more number of factors that you had pre-transplant, the more likelihood of cognitive impairment post-transplant, probably just due to having like a fragile brain pre-transplant with diabetes, alcohol consumption, and a history of hepatic encephalopathy. Other ways of looking at prognosis, I think we're all familiar with the MELD score for cirrhosis, but people have also looked at the MELD score to look at prognosis for alcoholic hepatitis, as well as in patients with cirrhosis, looking at, comparing it to the discriminant function as well as, just Child-Pugh score. And what they've shown is that the MELD is really comparable to the MADRI in predicting 30 and 90-day mortality. So this is another useful scoring system to kind of determine whether people will need transplant or not. And then there's also the Lille model, which looks at baseline data, so age, bilirubin, and albumin, and looks at really the change in bilirubin at day 7. And so for patients who have severe alcoholic hepatitis with a MADRI greater than 32 who are started on corticosteroids, you look and see if there's been, an improvement in the bilirubin at day 7 or at day 4. You can also look at day 4. There's been some data. But what that shows is that, if there is a response to prednisone and the Lille score is less than 0.45 and they're a steroid responder, there's an 85% chance of 6 months of surviving at 6 months, versus people who are non-steroid responders, their likelihood of survival at 6 months is only 25%. And then what about, so this is, these are prognostic scoring systems in alcoholic hepatitis. What about in cirrhosis? There's a recently defined entity called acute on chronic liver failure in patients with cirrhosis. And it's a syndrome characterized by systemic and hepatic inflammation and altered host response to injury. And it's characterized by an acute deterioration of liver function and organ failures. And obviously, with the organ failures, a high risk of short-term mortality. Excessive alcohol consumption is one of the most frequent events precipitating ACLF globally, but particularly in the West. But there's still a lot of questions around ACLF and whether alcohol-induced ACLF is a distinct form of alcohol-related liver disease, or is it just a progression of very severe alcoholic hepatitis? So in this study, they looked at the prognosis of patients with ACLF, and they used this CLIF organ failure scoring system to determine if they were ACLF 1, 2, or 3, and basically just referred to the number of organ failures. So like it could be liver as defined by the bilirubin, kidney defined by the creatinine, brain defined by the hepatic encephalopathy, coagulopathy, whether they required pressors or not, or required intubation. And basically, what they showed was that the 28-day cumulative incidence of death varied considerably amongst patients. All of these patients had biopsy-proven severe alcoholic hepatitis and a MADRI greater than 32. So they were all considered severe. However, if you had 3 organ failures, your 28-day incidence of death was 72%, versus if you had no ACLF, 10%. So definitely, this gives us additional information to see how likely are these patients to survive over time. Can they wait for transplant, or do they need to be transplanted now? And what you can see here is that the level of response to corticosteroids decreased significantly depending on the ACLF grade. So I think one of the criticisms of the STOP AH trial was that, patients were maybe not sick enough. And it does show here that, corticosteroids are useful, but there definitely does appear to be a point where you're too sick to likely respond to steroids and probably need to go straight for transplant assessment. What about in patients not necessarily that sick? And a Maddrey less than 32, because we've been talking about Maddreys greater than 32. Well, this paper demonstrated that even if your Maddrey was less than 32, your long-term survival was impacted. So of 121 patients who presented with decompensation and a biopsy showing steatohepatitis, their 1-year survival was acceptable at 80%. However, their 5-year survival was only 50%. And some predictors of the long-term mortality included the presence of encephalopathy and the lack of alcohol abstinence. So really, these patients who are coming in with alcoholic hepatitis, they come to emerge, they come to your clinic, they may be okay in the short term, but if they are not abstinent of alcohol, they are likely to come back again and again. So I think this just really focuses on the importance of abstinence so that your patient you see now, you don't see later down the road. So just the first reflection that I want you to do, and please feel free to ask any questions if you'd like, is, when this patient comes and sees you, because you guys really are seeing them first, really try to determine what is their prognosis. Do they have alcoholic hepatitis? Do they have chronic liver disease? Do they have ACLF? What is their 3-month, 6-month survival? Do they need to come for transplant assessment? Lil score and trend in bilirubin can be very useful in determining that, and really very important to link patients to addictions resources. Even if they don't need a transplant, important to link them to abstinence. So I'm going to ask you guys a question. Going back to our original patient, do you think that she has alcoholic hepatitis? Is it severe? And what is her 6-month mortality? I know people sometimes, you don't have to answer. You can also just kind of silently answer in your mind. But if
Uh,
anyone wants to comment or ask a question.
Um, I'll answer in, even though, again, I think as you were presenting the case, I tried to unmute, but then I realized that if I hit my earphone, it signs me off. So I had to log off, or it signed me off. But again, if you presented the case from below, again, it looks really bad, just based on her renal dysfunction, her bilirubin super high. And so I think her 6-month mortality looks bad. I was actually flipping back also in the chat, and I think one of the questions that had come up was with regards to using the MELD score and whether or not, the adoption of MELD 3.0 or MELD NA. Is there a preference? Again, is it just you use a calculator and sort of based on that?
Yeah, no, I think that's a good point. They used MELD score. We use sodium MELD. The cutoff has been 21 that people usually say, but I think, with all of these scoring calculators, like there's a little bit of a gray area, right? They're not perfect 100% sensitivity specificity, and you can use multiple ones. So I think if you have someone with a high Maddrey, a high MELD, it's appropriate to think of transplant at that point. But yeah, it's usually, I believe that paper used MELD. We usually use sodium MELD. So if you have a sodium MELD of 21 and a high Maddrey, and exactly as you're saying, she has like multi-organ failure. So like severe, like ACLF, like grade 3 to grade 2 to 3. So, she, no matter which scoring system you use, she's had like a high risk of dying over the next 6 months. So, I think, we use the cutoff of 21, but, if it's, there's a little bit of leeway there. It's interesting because I thought someone would ask me, everyone always asks me, like, what PT do you use for the Maddrey? So I think, it's interesting because I read a paper that, like, it doesn't really matter. like using different cutoffs of PT. So I kind of feel like it's kind of the same principle, like in that paper, it didn't show any difference in survival. It did impact who got steroids or not, but didn't actually impact survival. So I feel like, this is the goal of having all of these different scoring systems is, you can kind of get a gestalt feeling if this person, requires referral or not. Okay, well, thank you so much. So I'm going to talk now about, if you've decided this patient is quite sick, how do you actually get this person to liver transplant? And so I'm going to speak specifically about pathways to liver transplant at UHN. And I actually joined in 2021. So it's really, I have to like give all kudos to my colleagues who started this pilot project in 2018. And they actually published their results in Gastroenterology, and I'll be reviewing that. So some of these slides are courtesy of our transplant psychiatrist, Dr. Jose Lynch. And so the goal of the ALD pilot program was really to develop a standardized referral and listing criteria so that really there was equitable access to transplantation while balancing the utility of resources. And they were able to operationalize this multidisciplinary team to assess suitability and to provide treatment and follow-up. So it was no longer hepatologists determining whether, patients with an alcohol use disorder were suitable to receive a transplant or not. They really wanted to identify those patients with ALD who would have a good prognosis with respect to a risk for relapse to harmful alcohol use, and really to assess the utility and equity of a change to the 6-month rule in Ontario. So predictors of return to harmful drinking, this is why we use the 6-month rule, because we wanted to predict who would relapse post-transplant. But unfortunately, duration of abstinence is really not that helpful. Relapse is extremely common, and sobriety really only becomes robust only after 5 years of sustained abstinence. Studies suggest shorter sobriety periods are predictive of future relapse, but there's a lot of like gray area with the definition of alcohol use, and there's not a lot of consistency. Um, there are other negative prognostic factors like comorbid psychiatric conditions, if you have a diagnosis for an alcohol dependence disorder, social isolation, and other substance use, that you really don't get that flavor when you just say, oh, you haven't been abstinent for 6 months. So really they use a combination of biopsychosocial factors to really determine whether patients should be declined for transplant. And so just to highlight a few, they do look at the psychosocial suitability. So do they have an alcohol use disorder? So i.e. this chronic relapsing biopsychosocial disorder of the brain with a compulsion to drink and use despite negative consequences. Do they have a relapse history? And if they do, did the patient reach out for support? Were they able to discuss the relapse and work with a treatment team? Were they willing to engage in treatment? Were they willing to commit to abstinence? Surprisingly, there are patients who tell us that they will not do AUD treatment. And is there a substance use or psychiatric history? So studies have shown that untreated psychiatric disorders likely interfere with treatment adherence, and it's been independently associated with a return to harmful drinking, so anxiety or depression. And then we also look at, is there an adequate support network? Is there stable housing? Are there financial resources? And we do use biomarkers. So we use urine ETG, which is a metabolite of ethanol, which can detect alcohol consumption for up to 5 days. So our patients do urine ETGs at baseline and then random ETG testing while they're on the list. And these are sent out to Life Labs. So Life Labs, I believe it's free to do the ETG. If you go to Dynacare, they might charge the patient, but you should have access to urine ETGs. So these really enforce the Trillium listing criteria. with patients willing to commit to abstinence, willing to commit to AUD treatment, absence of, active substance use disorders, stable housing. But, I'm gonna, talk about, go through the study, because even patients who failed some of these things, we do
Also, wouldn't
say
mind
they can
getting
be
my earphones,
re-referred.
but
Oh, I'm sorry.
do you want me to
And
get something from the car?
oh, I think and then it is possible to be re-referred if those things are no longer an issue. So the second reflection, and this is a group of hepatology colleagues who are all out having a good time with some alcohol in moderation. I was taking the picture, so I'm not in it. But so the second reflection is that there is no 6-month rule, and really it's a biopsychosocial determination to see if patients are able to undergo transplantation.
I find, sorry, Cynthia, again, I
Yeah.
find that like this is for me really important, especially the inpatients that we see, sort of getting away from the concept of or the mindset of the 6-month rule. But probably for me, I find it very important to get the social worker consult in early, because I find that that's often the predictor of, how engaged, how much change, how supportive the patient is, because oftentimes that's sort of the deciding factor in terms of the patient's ability to go undergo transplant. So the key message, I think, is yeah, the social support.
Absolutely. I think, 6 month was easy for us because it was black and white. And now it's much more difficult to make the determination. We need a lot more information. And these are very sick patients who are encephalopathic, very, very sick. Their status changes day to day. One day they can give you a history, the second day they can't. So I completely agree. I think social work is extremely important, even if they improve and don't require a transplant. That's I think study after study has shown that abstinence is really what determines long-term prognosis, and so social workers are very, very helpful to connect people to support. So I completely agree. Whether they need a transplant or not, the social work connection is super, super helpful. So for this patient, she was seen by addiction psychiatry in hospital. She is married, no children, fully employed, only smokes 4 cigarettes daily. She was treated for anxiety 2 years ago, but that's stable. And here, I'm not going to read out her alcohol history, but there was a bit of a red flag in that. She said she only drank, maybe a drink every 3 to 4 months, but she did have a DUI in 2016. Um, and then for all of our patients that we move forward with transplant, we make them sign a contract saying that they will be abstinent of alcohol. And actually, when we asked her to sign this consent, which says, I recognize I need to stop drinking, she actually tells us that she has not been forthcoming. She actually drinks 2 to 3 drinks of vodka nightly for the last 1 to 2 months, and she does not want to tell her husband or her parents. So, is she a high risk for relapse? I would say yes, but is there room for improvement? And I think this just illustrates the gray that our psychiatrists really have to grapple with, because as you can see, there's many different components that go into the determination. And so there's definitely negatives in that she was hiding her drinking, but then there's positives in that there's this willingness to engage in AUD treatment, and she has significant social supports, and she's able to work and all of these things. So I think just to emphasize, as these patients do have excellent outcomes. Um, patients who are transplanted for alcoholic hepatitis have equivalent outcomes to patients who are steroid responders and have excellent. Here we have here is the 2 year, 6-month survival, and here's the 2 year survival in patients undergoing transplantation for alcoholic hepatitis. And the return to harmful drinking is quite low. Many of the studies have shown about 10 to 17%, depending on how you define harmful drinking. But it is very, very important to identify those patients who are at higher risk because it does impact long-term post-transplant outcomes. So this study demonstrated that in patients who had a severe alcohol relapse, which in this paper was defined as 1 to 2 drinks a day for women and 2 to 3 drinks a day for men, about a third of patients had recurrent alcoholic cirrhosis. And of those, about half were decompensated. And once you decompensate, there was a high risk of death. So you can see here that, survival drops after transplant, after alcohol relapse, after a diagnosis of recurrent alcohol cirrhosis, and after your first decompensation. And overall survival is significantly higher for abstinent versus non-abstinent patients. So in this paper that looked at our patients, so just to go over, the specifics of what we actually do. So when we get an initial referral, it can be for severe alcoholic hepatitis or chronic liver disease. They need to meet certain criteria. So they need to commit to abstinence. They need to be willing to do relapse prevention therapy. There cannot be another active substance use disorder. They need to be compliant with medical treatment. There needs to be adequate social supports. So if anything is flagged during this, we may discuss as a group and say, these things need to be addressed before referral. But if it looks like they meet these sort of specific criteria, then they move on to a medical psychosocial assessment. And that includes being seen by a transplant hepatologist to look at all those factors that we discussed before, like these prognostic scoring systems. Then they're seen by an addiction psychiatrist to do the psychosocial assessment, and also very helpful to give recommendations on pharmacotherapy, although sometimes our patients are too sick to do pharmacotherapy. They have a social worker to assess the availability of emotional and instrumental support. And we are extremely lucky that we actually have an ALD addiction therapist. So a social worker with specific experience in addiction therapy. And she looks for, what is the relapse prevention therapy that best suits this patient. So there may be, one for seniors, or one for people of Indigenous background, or one for people who only speak, a certain language. So we're really, really lucky to have this person. And then we do a multidisciplinary meeting. If everybody agrees this person meets program criteria, they then go on to a medical evaluation. So sometimes you'll see these notes from us on the initial multidisciplinary meeting. This does not mean that a patient's actually been listed for a liver transplant. It just means that they've cleared the initial ALD criteria, and then they have to go on to medical evaluation. If they clear that, then they get listed. And so here you can see the huge numbers of patients that we've triaged that were declined for either medical or ALD criteria. And along the way, people do improve and no longer require transplant. You can see here that we will assess these patients, have a team discussion, decline further patients, and then they will go into medical eval, listing, and then finally transplant. So you can see this is why it takes us a while to list and transplant people. You can see from 700 to 44 people actually being transplanted as of the time of this paper.
Along the way, if Toronto General or UHN's on Epic, are these notes accessible? Because sometimes, the patients will tell us, I'm listed, and then really we see that they're just in the first phase of assessment. Knowing, I guess, our status, can we find that on Epic?
So we've heard the feedback. We're trying to do a better job. Our coordinator is supposed to document the results of all of our team discussions. I for sure always will put a note in Epic the same day because otherwise I will forget. She, I think, takes a couple of days to put that note in. So if there's ever any questions, because it's difficult, like we have our meeting on Friday at noon. So obviously it's very difficult to give you guys the most up-to-date info. So if there's ever any uncertainty, you can page the transplant hepatologist who's on call and they can let you know where this person is in the assessment. But for sure, we are making more of an effort to make sure that all notes are documented. And I think if it's on Epic, it should be available on Connecting Ontario.
Jokingly, that's good because they often come in on a Saturday.
I know, eh? It's terrible. Like for some reason, we take over on Fridays, and we always joke Friday afternoon, there's suddenly like 15 phone calls. So I don't have much more time left. I'm gonna go very quickly over these last slides, but here you can see the characteristics of patients who were declined. A lot of them were because of severe alcohol use disorder, likely to result in a return to problematic drinking, not willing to participate in AUD, not committed to abstinence. However, there's another paper that has recently been accepted where we demonstrate that a lot of these patients can be re-referred. And if they can have access to, relapse prevention therapy and, demonstrate a change in some of these factors, that actually we do go on and list some of these patients and they do go on to transplant. So a no is not necessarily always a no. So this number of patients went to medical evaluation, and then you can see here that about 64% proceeded to listing. Many were, some clinically improved, some unfortunately returned to alcohol, and some were declined during the medical eval. So that's why we do have to do a medical eval for these patients. The patients in the ALD pilot were sicker than non-pilot patients. As can be seen, like these, we've kind of, by waiting 6 months, we've selected out the very, very sick patients. So, these patients were not absent for 6 months, so they tended to be sicker at listing and transplantation, but they did have similar survival rates and similar rates of return to alcohol use as patients who were not in our pilot. I did have a couple slides about the medical evaluation, but I think in the interest of time, because I do want to leave some time for questions, I'm going to skip over them. But in general, we need to do a careful history and physical, cardiopulmonary assessment, abdominal imaging, lab studies. Any comorbidities that decreases the likelihood of surviving 5 years post-transplant to below 50% is deemed unacceptably high. And these are some of the other contraindications. So a big issue for our ALD patients is infections. I'll skip over malignancy, and then I'll just talk about this patient. So it was actually felt that she did have some positive features, and there was a lot of discussion, but she did go on to transplant. 1 year post-transplant, she actually did have a positive urine ETG. However, she was referred to transplant psychiatry. She was referred to our addiction social worker, and she's been able to work with them continuously. So that 3 years post-transplant, she has negative urine ETGs and normal liver enzymes, and has been able to follow up with our caseworker. So I think that it's controversial, but this, patient is someone who would have been declined, someone who is married with good social supports. This is someone we would have previously declined, and now are able to proceed with transplant under very careful and thorough assessment. So I'll finish off with that. Oh, actually, I'm sorry, I did have one more slide. What about post-transplant? So actually, after I finished my training in Toronto, I went to Ottawa, which does not have a liver transplant center. Um, and before I came back to Toronto, and I actually published a paper with a colleague in the US because, sorry, in the UK, because they have very similar sort of hub and spoke model where patients will be at their home center, go to the transplant center for the transplant, and then go back to the home center for all of the follow-up. And so what we showed was that in this very carefully curated patient population, because the patients that get sent back to these centers are obviously the ones who have done very well. They don't have a lot of surgical complications. The 1, 5, and 10-year survival was really very excellent. The most common causes of death was sepsis and cancer. And just, food for thought that if anyone is interested in transplant, Vince, you said you hired all these new people. So if anyone is interested in working closely with us, pre and post transplant, just let us know. So
I
with
will
that,
contact you and I'll connect you with, again, you've met most of them. I'll connect you with Angela as well.
yeah, would love to do that. And so with that, um, I'd left just a little bit of time if anybody has any questions.
I see a question from Dr. Hurwitz in the chat. He's asking, what's the current cost of liver transplantation? Does UHN accept out-of-country referrals? And conversely, do we track if listed patients go elsewhere, i.e. US, for transplant?
So these are excellent questions. Do I know what the cost of liver transplant is? I do not. I'm so sorry. It's probably in the hundreds of thousands of dollars. I'm so sorry. I don't know the exact cost. Does UHN accept out-of-country referrals? So I do believe that our live donor program does accept referrals from out of country. So usually if patients are, I'm assuming you're talking about live donor. So what happens is, if patients are coming for live donor liver transplant, they do need to be considered candidates for deceased donor transplant. So we will not transplant people outside of criteria. So for example, if someone had alcohol use disorder and wanted to be transplanted at UHN, they would still need to meet our criteria. But I believe there is a program. Unfortunately, it is not covered by OHIP. So I guess maybe that relates to your first question on how much it would cost the patient. A lot, a lot of money.
I guess we do see quite a bit of non-OHIP, again, different statuses, either sort of new to Canada in some fashion, students. Again, I'm just curious, if we are seeing individuals with like an acute liver failure, they potentially are heading in that direction. Are they a no or still under consideration? Are they individuals that we would contact you with regards to?
Yeah, that has to be on a case-by-case basis. So if someone does not have OHIP, then they won't be able to pay for lab work, medications may be difficult. So in general, if patients have chronic liver disease, and they have the ability to go to a place that has a transplant program, we would say, go back to that country. For patients with acute liver failure who are going to die, we have made exceptions and it's on a case-by-case basis, and we have to speak to our program director because, it's not really about the cost of doing the transplant and the hospital stay. It's about preserving that graft afterwards. And it's very, very tricky because you don't want to do the transplant and then you have no ability to monitor the graft, take life-saving immunosuppression. So this always has to be a discussion with the transplant group. But you can definitely call us if you feel like, this is an emergency situation and we can have a discussion as a group if we're able to get the funding. But that's kind of over my head. That's our multi-organ transplant director has to sign off on these things. But I would say it's not like a 100% no, like right off the bat, like still call us and we can have these discussions.
Right.
And then I actually do not know if we track patients who go to the elsewhere for transplant, although I would say that we do get a handful of patients who go to other countries for transplant, say like China or Turkey, and then they do request for their care to be done here. And it's usually very, very few patients, like a handful, at least in the liver transplant side.
I see one more question from Matt Chia. He's asking, can you comment on BMI cutoffs and pathways that exist for obese MASL D/NASH cirrhotics with BMIs greater than 40 at UHN?
So this is a fantastic question that we're actually going to be reviewing as a group at our program retreat, because we are seeing more and more MASH/NASH patients. Theoretically, if you look at Trillium, BMI of 40 to 45 is a gray area. BMI greater than 45 would be an absolute contraindication. However, in other programs, they've looked at doing bariatric surgery, pre-transplant, bariatric surgery at the time of transplant. So we're discussing as a group whether we would potentially accept, patients who have higher BMIs. And it's always a bit tricky with BMI because also, if you have a decomp patient with a lot of ascites, like we're going by dry weight, like if, there's 20 pounds, 30 pounds of ascites, then we may think that the BMI is a little bit lower than we actually think. But these are great questions, particularly now that, there's all these new weight loss drugs. So the question is, could you take some of these medications and try to lose weight, pre-transplant as well?
Okay.
I
don't see I don't see any other questions in the comments. And I think we are coming close to time. So again, I just wanted to thank you again for an excellent talk. I think it's really helpful because oftentimes in the community, we do see the patients that are, their livers are failing, they're heading towards the need for transplant. And I have seen in the last couple of years, the openness in terms of reaching the transplant team. And again, it may not be a yes now, but sort of at least getting an objective assessment for the patient, for which we can send feedback to the patient, and at least we know what we can do for them.
And I'm just gonna say our clinics are on Thursdays and we discuss patients on Fridays. So send referrals to us early.
Okay. Janet, I was going to bring up the issue with regards to the hepatic encephalopathy order set. Right now, again, it's still sort of to be finalized. So again, there'll be more information that comes forward once that order set has been completed and about to be launched into our Epic. Okay. If there's no other questions, again, I just want to thank Cynthia and Janet for sponsoring the rounds today. And again, if there's any other questions, you can reach out to me and I can forward them to Cynthia as needed.
Thanks very much. Have a great afternoon.
Great presentation. Thank you very much.
Thank you.
Thank you.
Thanks, Cynthia.
Thank you.